Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Thank you for joining us for episode 2 of our 2-part series on ethical consideration and medical error communication. We're going to continue this discussion building on the foundation laid in our previous episode to take a deeper look into the nuances, limitations, processes, and stakeholder perspectives involved in upholding ethics around medical error communication. So if you have not, make sure you take some time to listen to episode 1. Dr. Jane Stowe is here to continue this discussion with me, so we're going to hop right into it. How can healthcare educators better prepare future providers on the ethical and communication skills needed to handle medical errors?
Hey, great question. And that's really where you need to focus this, the future of the discussion of medical errors is how do we make a true impact? And I think it really is focused on the group of individuals that you're talking to. And by that, I mean, look, if you're talking to a bunch of nurses in a hospital, explain the fact that, hey, look, let me tell you about our structure. Never have I sat in a hospital where the structure and legal liability is discussed when reporting. Those fears have from the frontline personnel are not alleviated. So if I were to come to you and say, hey, look, hey, Candace, here's what we've got going on. We've got a great new reporting structure, right? Event reporting system. So we want you to report errors, near misses, things that just didn't go well, right? May have ended poorly. We're wrong. And you know what? We're going to establish a culture and an environment where if you need to enter one, your charge nurse is going to come relieve you so that you have the time to enter it, okay? Not try to squeeze another action in your already busy day. We want to make sure you do this. And why we're doing it is to prevent errors going forward. Does that sound like a good idea? Yes, it sounds like a good idea. I said, well, let me tell you what. We're going to do this through the quality department where everything you report is private. You're not going to get in trouble for reporting these actions as long as there's nothing intentional, right? Like if you intentionally did something, well, then we got to have a sit down, real talk. But again, if it's an error, let's report it. Okay. This is not something that's going out to our attorney. This is not something that's staying within the hospital. It's in the quality department. And we're going to discuss these things to try to prevent errors in the future. I think if you have a real conversation about things and how it's reported and how you're protected yourself, how you're given time to do this and not have to add just one more thing. If you talk to a nurse in a hospital and say, oh, you want me to document one more thing? One more thing? Well, it's one more thing every day, right? And they don't do it. They're out of time. They're out of time, and there's fear of repercussion. From a physician standpoint, or maybe a nurse practitioner or some of these other entities that take more direct care of patients as far as writing orders and directions, I think you have to change the switch a little bit, right? Because they don't necessarily work for the hospital. They may be a contract employee or given rights to work in or privileges to work within the hospital.
Right.
So they're a little bit different setup, but I think that's where you change things and say, we do talk about the structure through the quality department and protection, but we also talk about, and I think what's impactful is you bring someone like myself in that's an attorney with experience and you say, look, guys, let me just tell you. Ladies, this is the reality and this is the facts, okay? If you go in there and you do X, Y, and Z, you're going to mitigate your risk for lawsuits. Now, can a lawsuit still be brought? Sure it can. People ask me all the time, hey, can I file a lawsuit for something? You can always file a lawsuit for anything you want. As long as you pay the fee to file a suit, you can file it. Doesn't mean it's legitimate. Doesn't mean it's not going to get thrown out the first time the judge reads the first letter. Doesn't mean any of that. You can always file something. So I think you have to gear the conversation a different way for the groups that you're talking about, but you've got to set a standard. And then you have to actually have, quote unquote, governing bodies within the hospital back you up, like back that standard and expectation up. So is the medical director, chief medical director of the hospital, chief medical officer, CMO, are they going to go to a surgeon and say, hey, look, you didn't enter this. You didn't tell me about it, right?
Probably not. Mm-hmm.
Probably not. However, you've got to get to that point where people are comfortable with reporting in order to truly effectuate change, right? Mm-hmm. If you're a nurse in the operating room when that doctor makes a mistake, one, do you have the same knowledge base as the physician? And did you know that an error occurred? Mm-hmm. You may not have, right? Or two, are you under such influence, or have you been influenced by the doctor to not report anything? So there's a lot of levels, hypothetical levels that you have to consider when doing it. But I will tell you, what if 20% more people comply with the just culture and reporting than did previously? Did you capture everybody? No. But think about the 20% of errors that you can address and potentially prevent going forward. So I would argue that any increase in reporting and addressing of those things and changing of processes and procedures is better for patient care. They're better outcomes. Yeah. So it doesn't have to be 100% to be effective.
So entering, I want to go back to where you're talking about, disclosing. So you're entering it, the severity. Is it according to the severity of the error, say a near miss, a minor harm, a major harm, what factors should guide how much detail you actually provide?
I think when you're reporting within the system, reporting your error, if it's structured properly, you can give every last detail, right? Mm-hmm. If you're talking about disclosing to the patient or family member, that's when it gets a bit hairy, right? The degree of disclosure, and disclosure in and of itself is risky. I say that when I say I want everybody to disclose things for improvement, but think about it this way. I'm a physician, okay? I've practiced for 20 years. I've built up a nice practice. I have a nice lifestyle. I have expenses larger than most. I've got a couple kids in college, maybe. Mm-hmm. I've got a lot of bills to pay. Mm-hmm. Everybody's got a lot of bills to pay, but maybe a little bit more expensive.
Yeah.
Something went wrong in childbirth. Okay, I'm an OBGYN. Something went wrong, and I'm going to go tell the family that, I failed to monitor something that could have prevented the poor outcome. Mm-hmm. If I go and sit at the boardroom table with them and I say, hey, I should have monitored this. Well, I didn't, okay? When you talk about a medical negligence claim, and it's the claim of action that you would sue for is negligence, okay?
Okay.
We all call it medical malpractice. That's kind of what we call it. But negligence has 5 elements. It's kind of roughly in 4. There's a duty to care for the patient, breaching that duty, causation, and there's a couple different steps to causation, and then the actual breach caused damage. So if I go to the boardroom table and say, hey, I failed to monitor this aspect. I admitted I had a duty. I failed to do it. I breached that duty. I'm admitting to you because I breached that duty, X, Y, and Z poor outcome happened. So my failure is the causal link to the damages that resulted. So I have at that table now made your entire lawsuit. I have met every element to be able to file a malpractice claim. And so this is really, so when you take that, you can go straight to court, and all you're now talking about is how many zeros are on that check. Yeah. Not a matter of having to prove those things. That's why some attorneys will say, don't say anything, because then they have to prove that you breached the duty. They have to prove that you caused the damages, and then they have to prove that there were damages. Proving a lot of things versus just handing that proof over on a silver platter is quite different. So, at what stage? I think there's just simply a fear, and the fear grows and the disclosure decreases in direct correlation with the degree of harm that resulted. If there's death, there's very few people disclose things. If there's permanent injury, some will disclose some, but it's smaller amount. If there were, wrong medication was given, no harm, no foul, disclose it all day long. Right? Because even if you take it even if you sue, if there's no harm, no foul, you haven't proved any damages. You've proved there was a duty to care for the patient. You proved there was a breach, but you didn't prove there was any damages, so you may not win the lawsuit. So I think it's in direct correlation with the degree of harm that is caused.
So also in disclosing to, say, the risk management department, quality department, I can disclose all of that there with them because I don't have to turn that over. It's not discoverable. Correct?
Correct. And so that is why you want to structure things, and you want to tell your people that, there's two different things. Reporting the error within your organization is not the same thing as sitting down at the table and talking and reporting it to the patient or patient's family. That's two different things. So reporting it within your institution allows for process improvement. Those individuals over the heads of that department get to powwow with the administration, and they will decide whether or not you get to step two, and that is sitting down at the table with the patient or family and disclosing it. So there's two very different things. So I would encourage people, the reporting within your system is a 100% plus, right? Because you can address those things, and you can find ways to improve and prevent errors going forward. That kind of takes a lot of that fear off the table. As far as sitting down with the patient and family, especially from a nursing standpoint, you really don't have to worry about that. Others are going to be involved, and they'll sit down.
Okay, so wait, I have a question now. I have a question. Sure. Okay, so we know that lawyers can be involved, risk management's involved, healthcare system administrators can be involved, and they play a role in this. Okay, I want to take just a case study. I don't know all the details in the Georgia case with what happened with the baby. I mean, I know what happened to the baby, and I know that nurses were sued. So I just want to take, if I was a nurse, which I don't really go to that end of the hospital, but if I was a nurse down there and that happened, and I went to the quality department or risk manager and I sat down and I talked to them about what happened, then they technically would guide what would happen next. So then as a nurse, I get sued because maybe I was told not to talk to the family. Am I covered? What happens there? Because I know nurses were named in the lawsuit for not being forthcoming about what happened.
Right. So that's interesting, and that can come up in trial. So it's a lot of difficult decisions have to be made, right, from those nurses and the hospital. The hospital more than likely dictated what was disclosed to the patient and family. Which more than likely, and again, I haven't read it, but more than likely said, we're not going to talk about this, or we will talk about it, not y'all. That's generally the case. Nurses haven't practiced in a quality department as a whole, haven't practiced in risk management, haven't had a lot of interactions with attorneys. They may know an attorney, their parent may be an attorney, they may also be an attorney, but you haven't actually had interactions while or during a lawsuit when you're an individual, right? So there's a lot of unknowns, and you don't know what to say, what not to say. So the hospital will generally guide that and guide the direction there. Now, if you felt like you should have told something, you felt like you should have disclosed it, those things, unfortunately, can come out in court through testimony. And the unfortunate part is you generally have to wait till court to get that out there. But then there's also, you run the risk of a believability standard at that point, right? Like, oh, sure, you can tell me now. Why didn't you tell me then? Or you wanted to, I'm sure. Yeah, you wanted to so bad you didn't do it, right? So it's, it is scrutinized more so. There are ways around it. There's questionings with a hospital representative that's put up and all kind of stuff. But yeah, generally speaking, the hospital that you work for is going to direct that narrative because, again, while the nurses are sued, the nurses worked for the hospital, and the hospital is the one that has the big insurance, right? Nurses generally are a path. Nurses, LPNs, pharmacy techs, pharmacists, all these people within the hospital are generally avenues to attach the lawsuit to the actual institution that has a much bigger insurance. Sad state, but that's the truth of a legal action, right? And they worked for them, and so that link can easily be made.
So, is there a time when it's ethically justified not to disclose an error to a patient, like maybe concerns over a patient's mental health?
I think that's a very valid question. And I think the easy answer is yes. I think there are those situations. But I immediately follow that up with, when do you disclose it and who gets to decide those answers? Because if you start down that slope of qualifying when someone should be told something, when they shouldn't for reason A or reason B or reason C, all of a sudden you create a scenario where you can abuse a system and use that as a withholding mechanism of disclosing errors. Now, that's a pretty cynical view, but I will tell you, of 25 years of seeing this, we think about, we run all of our error reporting through our quality department now, so that it's not disclosable, right? Not discoverable in court. So it's not far-fetched to consider the same ideological concept that we're going to use these excuses not to disclose. So, I think that at the end of the day, it should just be disclosed. It is what it is. It's an error. If I'm truly supposed to have autonomy over myself or my loved ones as far as directing their medical care, I want to know. Now, that's my personal belief. And not everybody's going to agree with that. And again, what happens when you tell somebody something and they have a physiological response to it, when in theory you should have waited to tell them, and their personal outcome is poor.
Right.
Then you can argue for the alternative or the other side. So it's a very difficult concept. I personally don't see any sort of middle ground on it. I think you've got to decide one or the other.
So what about are there different standards or processes when it comes to disclosing errors where maybe the patient can't make decisions? They don't have the capacity, maybe with minors or cognitively impaired adults?
We have most minor list a power of attorney, a parent, a guardian. If you're an older individual with a cognitive impairment, institutions can easily get a guardian ad litem at court as a representative. So, again, that's one of those resting your hats, arguably, on a reason not to disclose, potentially, when we have avenues to provide for appropriate representation of the patient that we can then disclose, and that person is then legally obligated to provide direction as to what medical pathway we want to choose. So I think, in that case, we do have options as far as adult representation, legal representation to direct care, even post error. Which way should you go now that error has occurred?
Right. through the majority of our conversation over these two episodes, I hear fear a lot. And I think we all have the fear of, number one, making mistakes. However, we are human and mistakes happen. We're not computers, and they're gonna happen. We talked a little bit about just culture in our last episode as well. So how can we really work to ensure, especially leaders, how can they work to ensure that error disclosures are going to focus on learning and improvement, and it's not about excessive self-protection and blame?
Well, that's the $1 million question, isn't it?
Isn't it though? Isn't it though?
That's a great question. You've got to establish a strong culture, a just culture, and really you can call it what you like, but you have to have a strong reporting culture. And what I have found over the years is many institutions have a very sincere desire to start this, to implement this, and to really effectuate change, right? For the good. Let's help patients. Let's do good. And all of a sudden, 6 months later, someone, spouse is in the military, they get transferred, they leave to another city, right? So all of a sudden, your reporting person that's evaluating this in the quality department is no longer there. Financial times are tight. Hey, okay, well, we're going to combine that with somebody else. You now have a point person. And what you see over time is this slow erosion of priority in this area. And over the years, over the months, years, all of a sudden it's, oh yeah, we do have that, don't we? Versus, hey, this is something we champion. And so if we don't keep this as a champion focused error prevention, then you're really not going to effectuate change. Because at the end of the day, those individuals you're bringing in as staff into your organization are learning the culture and the ways and the policies and procedures of those that are currently there. So those coming in are going to learn the bad ways if we don't fix those bad ways to begin with. And so it's kind of fighting an uphill battle. It can be won, but you have to keep it on the forefront as far as an organization. And you know what? At the end of the day, what you see from these type of focuses is it's a drain on resources, staffing, supplemental staffing, and cost. But what you don't see is 3 years down the road, the errors that it prevents and the money that you saved. So, your CFOs, while they understand the concept, have a hard time swallowing it generally because it's money coming out and I don't really see anything coming in.
Yeah. Kind of like the education department.
That's right. That's right. It's a tough pill to swallow. It's, but if you concentrate, and just like education, if you provide education, not only do you have better staff, you have better healthcare that's being delivered. Your length of stay goes down, your errors go down, all these things go down, which equate to very hard dollars. So, conceptually, it's a tough pill to swallow for some.
Absolutely. So I know we've talked a little bit about what's discoverable, what's not discoverable if, a lawsuit comes about. So how do we, when you're developing policies in your facility, I know some people like to use the term guidelines now. That was really big in a facility that I was in where we were like, no more policies, all guidelines. So what policies or guidelines or legislation would you recommend to better support the, ethical disclosure of medical errors in our system?
I think you really have to jump towards kind of the end argument of this, and then I'll explain that when I say, are we going to provide legal protection to those that disclose errors, regardless of the harm that is caused, or not? If we are going to provide that protection, then now we are able to open up the world of disclosures, right? So you take that fear off the table. So once you take the fear off the table, then you got to educate on your processes, and you just report, and then you do process improvement, and you truly change the way that you look and conduct business.
Mm-hmm.
If you don't provide that legal protection, then the fear is always there. It remains, because you're serving up all of those elements for a lawsuit. You're just giving it across the table and saying, please don't sue me.
Mm-hmm.
That's really kind of what you're doing, but you're doing it nicely. So the reality of it is, you can't just indemnify a profession, right? So how do you say, hey, just because you're in the healthcare field, you're indemnified from any wrongdoing? That in and of itself, I don't believe is ethical.
Right.
So now you're at a kind of conundrum of, what do you do? How do you take that threat of a lawsuit off the table? And I don't think you can. So when someone comes up with the miracle answer of how to take that fear and that threat of a lawsuit off the table, then I think you'll see much more robust error reporting and process improvement where just is really kind of hampered by that fear right now.
Absolutely. So as we kind of wrap up episode 2, what are some resources or trainings that you might recommend for providers on ethical disclosures and having these difficult conversations?
Time is a premium for everyone today. I mean, it really is. I would encourage something very simple. Take 5 minutes and just Google whatever your search engine is, whatever your preference is. I say Google just because it's big and it's out there. Whatever your search engine is, type in there and just say, hey, medical error disclosures, risk mitigation, lawsuits, and talking to families about messing up. Okay. It's going to give you some data, and you can read it for yourself, that says, hey, look, you know what, it is a better thing. Talking to patients, it really is the patients, you establish a better patient relationship because you came to them, you talked to them, you told them what happened, and you told them what you're going to do going forward to help fix it or do the best you can. You'll be surprised. People actually stay with those doctors that come and talk to them because they know they're going to tell me the truth now on. I mean, it's kind of a strange concept. I'm going to stay with you because you messed up. But it's true, and you reduce litigation. So I would encourage you to look at those things. And if you're not real sure how to have that conversation, talk to your risk department. If you're a provider looking at this, if you're a nurse looking at this, dental assistant, pharmacy tech, whomever in the healthcare field, Google, understand the reasoning, and then talk to some people that have been involved in risk management, quality department on how to have those conversations. I'll tell you a quick side note is when I was one of my early career in nursing, I worked in a trauma and burn intensive care unit, and it was staffed by a second and third year surgical resident. Okay, every day. Fourth and fifth years would go in OR, what have you, but they would care for the 12 patients in that ICU. Patients would pass, and these individuals, these doctors would have to go and talk to them, the families, about that. It was very quick that I realized, for my own sanity, that I was going to go with the doctor. I was going to do the talking and let them answer the big medical questions, because we don't train people how to have those difficult conversations.
Right.
This is a difficult conversation. You've got to learn it. So if you don't know it, don't be afraid of it. Reach out for help. Grab those individuals that have been there, that know how to do it, and let them guide you. Okay? It's okay to ask for help, even in this situation. Your patients, the patients' families will greatly appreciate it, and you'll be surprised that even through an error, what sort of difference you can make in their life, a positive one.
One of the things that I remember from the RaDonda Vaught trial was that the family is not the one that took them to court. The family was appreciative of her admitting and really saw her as a sincere apology And that's always really stuck with me through that whole trial with her and all that she's been through.
I think that's a great example of you disclose, you show your sincerity, your true sincerity, and it doesn't bring a lawsuit. That's an example of the exact fear mitigation that we need.
Absolutely. This is such a great conversation. Thank you so much, Dr. Stowe. We have come to the end of our time for this series. And one of the statements that I made in the very beginning of this series in episode 1 was that ethical considerations surrounding medical error communication are multifaceted. And I think that this conversation today really shed light on the need for a multifaceted approach, from robust processes and training to open dialogue and empathy. And every stakeholder is going to play a crucial role in fostering an environment of trust and accountability. Challenges exist, and of course, they're going to continue to exist. And so as healthcare providers, we have to stay committed to ethical communication. It lies at the heart of everything that we do, to include patient safety, healing, and the preservation of the sacred trust between healthcare providers and those they serve. Thank you, Jay, for always bringing so much insight into our discussions. It's always such a joy to have a discussion with you.
I really enjoyed it, Candace. It's been an honor to be here. Thank you so much.
Absolutely. And to our listeners, I encourage you to explore many of the courses that we have available on elitelearning.com to help you grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.